Welcome, everyone. For those of you who are joining us for the first time, iCourts is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical disease. Once a month, iCourts hosts a Knowledge Café webinar where we provide the opportunity for community members to present on a topic of their choice to a global and virtual audience. If you have any ideas for a Knowledge Cafe, please reach out to us at info.icords@gmail.com. And if you'd like to join as an iCords member to stay up to date on our activities and events, scan the QR code on the right side of the screen to sign up. This webinar was developed in collaboration with the International Coalition for Trachoma Control, who will present their work on the development of a toolkit for trachoma interventions targeting special populations. During the session, please feel free to put in any comments or questions you have in the chat, and we will address them in the discussion portion of the session. Please note that this session is being recorded. To introduce the session, we have ICTC Special Populations Co-Chair Amanda Bradica from ITI. Welcome, Amanda.
Thank you, Varsa. Greetings, everyone. My name is Amanda Bradica. I am the Senior Operations Specialist at the International Trachoma Initiative, and I'm also the co-chair of the ICTC Special Populations Task Team. The International Coalition for Trachoma Control, or ICTC, is a multi-stakeholder collaboration platform for non-governmental organizations, academia, donors, and industry, working together with the explicit goal to reach global elimination of trachoma as a public health problem by 2030. ICTC enables a platform for our members to identify gaps in the global trachoma program, share learnings, develop preferred practices, and coordinate joint programming and advocacy efforts to mobilize resources. Significant progress has been made towards trachoma elimination, including a 94% reduction in the number of people requiring interventions globally since 2002, and 27 countries have validated by WHO as having eliminated trachoma as a public health problem. Within the global population at risk of trachoma, however, some groups face additional barriers to accessing interventions due to social, ethnic, cultural, religious, and/or geographical factors. So these special populations is what we term them within ICTC. And the populations include, but are not limited to, refugees, internally displaced persons, or IDPs, and Indigenous and nomadic communities. These groups are often referred to as statistically invisible, as their disease burden may be masked by the dominant population when doing population-based surveys. Achieving equitable access to trachoma services requires targeted efforts to identify and reach these groups, remove systematic barriers, and tailor interventions to their specific contexts and needs. So that's why ICTC established the Special Populations Task Team to identify these groups and identify strategies to reach them. So with that information, I am pleased to introduce my two co-chairs, Chad MacArthur and Dr. Angelia Sanders. Chad is an active consultant working with ICTC and other NGOs to help strengthen trachoma program delivery. And Dr. Sanders is the Senior Assistant Director for the Trachoma Control Program at the Carter Center. She possesses nearly 20 years of experience focused on disease surveillance, intervention coordination, and health education with a particular focus in South Sudan. Due to her involvement as the executive group member within ICTC, she has been instrumental in the development of a Trachoma Toolkit focused on special populations for program managers to use. And so with that, I would like to hand it over to Dr. Sanders for her presentation.
All right, hello everyone. We practiced sharing my slides. Let's see if we can do it on the first try. Does that work? Yep, okay. I'm seeing a smile from Amanda. As mentioned, my name is Dr. Angelia Sanders, and I'm very excited to talk about the toolkit for special populations that we just launched last year. What I will do is briefly talk about the task team itself and our approach to developing this toolkit, If this is, I think it's always helpful to know how people developed these types of things in case this is something that you are also interested in. I'll then talk about the toolkit itself and then next steps. First, I would like to acknowledge the significant contribution of the ICTC members and observers who worked on this toolkit. We had about 35 people that were part of the working group from 15 different organizations. And you can see here the different representation. And it was nice because not only did we have those perspectives from the headquarters levels, but also from the country levels. And so each person really brought their experience working with special populations. All right. As mentioned, these were the 3 co-chairs of the task team or the working group. Now, when we say special populations, that is always, I think for those of you who have been part of task teams or working groups, is what is your definition? How are you going to narrow your focus? We set this definition just to help guide the group. And for us, special populations were those that were due to various factors require programs to be tailored, so adjusted a little bit to ensure equitable access to trachoma, but also NTD programs in general. We primarily focused on refugees, internally displaced persons, Indigenous and nomadic populations, and then also those who might be living with disabilities or experiencing homelessness. As Amanda mentioned, these are often the groups that are statistically invisible to health programs because, especially in trachoma and I think NTDs, we frequently look at the district level prevalence and we measure our success based off of reaching at least 80%. But what about those populations that are small, but they still need services? Our approach was first to do an inventory to get a sense, is this a problem? In a lot of meetings, you would hear people say, displacement is a big problem. Refugees are a big problem. But we wanted to know if that was actually the case. And how did that displacement or these special groups connect to being in trachoma endemic areas? Because you may have refugees in an area, but that's not an area that's endemic for trachoma. Or for those of you working on other diseases, they may not be endemic for things like river blindness or LF. So first we wanted to look at the data. Then we wanted to tap into a lot of the knowledge that was within the communities. And we did that through case studies, which I'll discuss. And then we the toolkit. So here's an example of our initial inventory. And we did this for many countries. Here we use Yemen. Yemen was a country, and unfortunately still is, that is security, and that has led to a lot of refugees and IDPs. So we looked at the various districts, the health implementation units. We wanted to know the population in those units, and then the type of communities that fell within our special populations category. So in this case, we looked at IDPs. We wanted to know, was there trachoma in the host community? Was there trachoma in the IDP population? And what kind of services had been done? So that's an example of an inventory document that we created. We also did case studies, so reached out to various programs and countries to say, what are the lessons learned? What are activities that you have been doing? And these case studies were put on the ICTC website. So you can go to the website if you want to see more in-depth information. I will stress that we are always looking for additional information. Within the community, we continue to learn, and it's important as we learn that we document it. So if you're looking at some of these examples and you're thinking, oh, I would like to highlight my work, please reach out to us. And then lastly, we wanted to build on the work that had already been done. So within the NNN, which is the NTD NGO network, there is a working group that looks at implementing NTD programs in conflict and humanitarian emergencies. And this working group had already developed a toolkit about 5 years ago. So we wanted to take the information that they had already developed, pull that into our toolkit, and then add on the additional groups, because though that group looked at conflict affected areas, we were also looking at conflict, but also other groups like those who move seasonally or migrants. And we wanted it to be a little bit more comprehensive. So we really were able to build on the work of other groups. So having that different streams, having the inventory, having the case studies, having the work of other working groups, we compiled this toolkit. And the goal is for it to be used, it can be used multiple ways. So first, as a guiding resource for organizations with limited or no experience working with special populations. So maybe this is something new for you. A step-by-step planning guide for organizations who are already engaged in these areas, but they want a little bit more structure to their activities. As a reference document outlining key planning components or documents, tables, these things that could be used. And then also as a tool to engage non-trachoma partners in the planning and delivering of trachoma interventions for special populations, maybe either through partnership or through integrating with other diseases. Based off the information we collected, we saw about 6 themes, which we put each theme into a different chapter, and I'll discuss these chapters a little bit later, but they looked at situational analysis, surveys, key partnerships, security, effective planning for implementation, and advocacy. And then throughout the document, we have case studies. Just have a whole bunch of written text saying this is what should be done, but we wanted to give examples of how it has been done in order to make it more real. And so some of the examples of case studies are surveys that were conducted in Indigenous and non-Indigenous areas of Brazil, partnership work in refugee camps in Sudan, conducting security assessments before trachoma surveys in Nigeria, addressing insecurity as part of trachoma work in Yemen, applying gender equity or social inclusion approaches in Maasai communities, and assessing the prevalence of trachoma in refugee camps in Cameroon. And I've taken a screenshot so you can see kind of what that case study looks like. So we have a paragraph about the work that was done, connecting it to the concept within the toolkit. But if it's something that's of interest, where we had additional information, we put a QR code so that if you are really interested in the work done in Cameroon, you can use the QR code to get more information about that particular activity. In addition to the case studies, we also have a good appendix section at the end that provides additional resources that help support the chapters. So, for example, we list a checklist of key contextual considerations for a situational analysis, key components of micro-planning, choosing health workers, an interactive field tool, so things to consider when you're picking your team, when you're working with certain groups of people, additional survey considerations, example of a mitigation plan, for example, if there's insecurity, and a serious incident report example. So now I'll talk briefly on each chapter, some of the key themes within the chapter and areas of consideration. So the most important thing is conducting a situational analysis. And this is a systematic process to understand the local context for the health intervention that you're seeking to implement. And it's really important to move beyond the assumptions so that you're developing a tailored, trusted, and effective strategy. And the things that you're looking for in the local context is healthcare access, the community structures. Is there conflict? What are the migration patterns? How does that impact how people access health services? What are the beliefs, the gender dynamics? What are your communication strategies? Is this a community that they mostly get information from the radio, or is it through community events? Looking at health systems and policy, are there gaps? Are there existing programs? Are there guidelines around these groups? And then what are some of the challenges that you need to understand in order to be able to overcome them. So are they geographically isolated? Is one of the reasons they're not being reached is because they live in a mountainous area and most of the programming is being done at the lower level? Is there legal status implications? Social and cultural hurdles? Is there a lot of distrust within the community? Is it government they distrust, so you need to think of other groups to involve in your health interventions? Is this a population that moves? Is it one that constantly moves, or are there seasons to their movements? And in order to overcome those strategies, you need to look at building trust, engaging communities. Are there opportunities for integration and coordination with other programs? And as much as possible, using data in order to develop your programming. For the surveys, this we felt was a really important chapter because a lot of the original work, when we conduct baseline surveys, and I think this is for not just trachoma, but other NTD programs and health programs, we had a very structured way that we're going to generate a prevalence for the district and it will be done this method. But now that we know that there are different communities that could be left out of the sampling frame, what do we need to possibly consider when we are planning surveys to either get a sense of the disease or measure the impact of our programming? So we talk about sort of the current methods of conducting surveys, but what are ways that they can be adjusted for the local context? And with that, we look at the sampling frame, ideas to consider. For example, if you have a refugee camp in a district, this is what it could look like if you include the refugees in that district prevalence. Or is it a situation where you do a separate survey for just the refugees? And we provide those kind of ideas to consider, but also sampling methodologies if you're considering doing different types of surveys for different types of groups. We also discuss about the importance of collaborating with other organizations or sectors. I have found that this is especially true when it comes to getting data. So for example, in Sudan, where we have refugees from South Sudan, the program went to UNHCR, which had very good data on the refugees, and they were able to get that data and they used that in order to develop a survey methodology. Also with surveys, things to consider, and I know this is obvious, but safety first. And it's not just about safety for the survey teams themselves, but also the community. How do you evaluate the safety, and how do you use that to plan your activities? We also discuss ethical engagement and being aware of what your presence can do and the questions that you ask, and thinking through who is also on the team, the languages that you use in order to collect data, and how that information is shared. One of the things we're seeing recently is, I think like 15 years ago, a lot of our surveys were done using paper, and almost every program has moved away and they've started collecting data on tablets or phones. And that's because it's a lot faster when you have it electronically. But now there's been multiple countries and situations because of insecurity and the government not wanting electronics that have GPS capability being used, programs are now having to switch back and use paper forms. And so these are the kind of things to consider in certain contexts. We also discuss where there's interruptions. Maybe your program gets delayed. What does that look like on your surveys? Or if you have to replace one of your clusters or your villages, because when you started the survey, things were fine. And then a week in, there's insecurity, and where you had originally planned to go is no longer accessible. So what are things that you can do as a program to respond to those changing environments? The next chapter, just a second, it's not, okay. There we go. Next chapter looks at key partnerships. some of it overlaps a little with the situational analysis, but stakeholder mapping. Who are the various stakeholders in the communities where you're working? And that can be other NGOs, government programs, and also people within the communities themselves. What are formal and informal agreements that you need to get in order to implement your program? Are there MOU, memorandums of understandings that you need to have with different groups? Do you need clearance from certain government entities or humanitarian agencies? Like I said, if you're working with refugees, you might need permission. Likely, you will need permission from those that are managing the camp in order to go in and do activities. I think a theme that we've seen throughout really all the chapters and just working with special populations is the importance of building trust and really strengthening those relationships. So being aware of the staff that you hire, how you communicate with communities. We also discuss gender equity and social inclusion principles, how to incorporate that within your program, and being just very thoughtful in the representation and engagement with women. And then lastly, cross-sector collaboration. When you're working with groups, being aware of things that are important to them and how can you connect your NTD activities with other programs. And one of the case studies within the toolkit was from South Sudan, where this one particular community that is highly nomadic, cows are one of the most important aspects of their culture and their livelihood. And so the Trachoma program partnered with a cattle or veterinary vaccination program. And so on one side, you had people bringing their cows to be vaccinated. The cows got vaccinated, and then those men went to the next station and they received the drug for trachoma. And so recognizing that you're meeting the needs, one need of a community and partnering with that organization, and then meeting another need of that community really helped the program have a higher impact. For security, we discussed the importance of conducting security assessments ahead of time to evaluate potential threats, and more importantly, how you will respond to those threats. What are considerations you need to plan for in advance in regards to staffing, budget implications. We know that in areas that are insecure, it's usually more expensive because you have added needs of the program. So when you're budgeting, do you need to account for a security assessment? Do you have to have extra fuel with you in case you need to evacuate? The length of the activities may take longer. Are there security clearances? So we discuss various things that should be considered ahead of working in these environments. As I mentioned before, with data and electronic considerations, will you have to use paper-based? Will you have to change the type of phone you have so that you don't have GPS in order to make those in the community feel more secure? We also talked about the physical and emotional considerations you need to think about. I think a lot of times we think about the security of a person's body, but we need to think about their emotional needs as well. In countries that have had a history of insecurity, the staff themselves, it's not just the community, it's also the staff who are implementing, have seen a lot and gone through a lot. So being aware of those needs is very important. We also discussed the importance of security incident reporting. As I mentioned, the appendix has an example of things that should be documented if there's a security incident. And then other considerations like who are NGOs and government in the area, branding, political sensitivities. Some of this doesn't relate just to special populations, but before an election, each party running usually has a color. You want to make sure that you're not wearing that particular color if you're implementing an intervention before an election. Just these kind of nuances that's important to be aware of. And here's an example of a table that we have within the toolkit, something to consider when you're planning to work in an insecure area. So documenting ahead of time, what is the estimated travel time and the distance? What's the road status? The security, police or military, is an escort required? Are you able to sleep overnight? Yes or no? Or do you have to come back to one location? Is there a curfew time? For your phone use, for data collection, mobile or satellite, you might be able to use one, but not the other. What's the type of insecurity and frequency? You know, security is very different. Is it sporadic and unpredictable? Do you know it? Do you know the types of groups that are involved in insecurity incidences? And then what is the target? Is it government forces? Is it those who are riding in an NGO vehicle because you look wealthy? And then the risk level. So again, just providing lots of examples of things to consider. Chapter 5 looks at effective planning for implementation. One of the biggest things was strategic timing and aligning with the community rhythms. So understanding the seasonal calendars, the daily work routines. If you're showing up in the middle of the day, but that's the time when everyone is in their gardens, that's not effective planning. So how do you adjust your interventions, especially for these special populations in these areas? It's important to know the cultural or religious events as well. Detailed micro planning, I think we all know, is very important, but is there an added element you need to consider when you're working with these unique groups? Strategic outreach, knowing and having relationships with trusted locals, and also very important, having flexible delivery methods. Maybe normally you're used to doing a central distribution for your activity, but you might have to go door to door depending on the situation. With training, it's important, as we all know, to really build up capacity, but we've seen this even more so with special populations. So for example, in areas where it may be insecure, the program may have had a history of those from the capital, they travel out to a location, they implement, and then they come back. But as access becomes more difficult, it is better to build up the capacity of those communities to be able to provide interventions on their own. And then lastly, how to document adverse events and manage those issues. The last chapter looked at advocacy. One of the things that we're really focusing on is, again, equitable access and leaving no one behind. And in order to get in order to get buy-in, that may require advocacy within your own organization, within the governments where you're working, and also among donors. So how do you expand the goal so it's not just about being below a threshold for elimination or eradication, but really ensuring that all people within those communities have had the opportunity to access those services? It's also really important to avoid stigmatization and blame. I have been in many meetings where people say, oh, we would have reached our targets, but it's those refugees, it's that tribe, they're the ones that are the problem, when in reality, they have not been given the opportunity to participate in these activities. And so we talk about the importance of the way that we talk about the issue to make it not a community's fault. And then lastly, with data collection, where possible, it's always good, the more data that you can collect realistically, the better, in order to document the activities of your program. So for next steps, hopefully by now you are very excited to read the toolkit. I've put multiple ways that you can access the toolkit. It is currently housed on the ICTC website in our resource library. So the website that I've put in the red box, if you go to this website, you then go to the resource library, you can find the document and download it. I've also put the QR code, so you can scan the QR code and it will also take you directly there. Now, unfortunately, we only have the toolkit in English at this time. We are looking for funding in order to have it translated to other languages. So if someone on this call is interested in funding a translation, please reach out to us, especially Amanda, and we can make that happen. The other thing is right now it is only online. I think it would be helpful to be able to have printed books. I find that printed books are easier to distribute within countries and become a more valuable resource. But again, we need money in order to do that. So another opportunity. So with that, I will close and we will open up to questions. And thank you.
Thank you very much, Angelia. We have about a half hour left in the time allotted to us, so we would like to use that time for questions or comments that you might have concerning this toolkit that Angelia has just presented, the applicability of it to your own situations, or comments on your experiences working with these populations. So we do have the chat open for questions or to raise your electronic hand, and we will call on you. So the floor is now open.
I think there's some questions.
So we do have a question from Taylor asking, what guidance does the toolkit provide for rebuilding community trust in settings where repeated interventions programs have led to fatigue or disengagement? Thank you, Taylor.
Yeah, thank you. Yeah, your question is good, and it I don't think we do. I think you've highlighted a gap. And Chad and Amanda or others who may be from the task team.
I think this is definitely something that we need to consider. And I think one thing that we would kind of, and I think Angelia alluded to this earlier, but we would like to treat this document, particularly since it's mostly online, as a living document, where such aspects as this for rebuilding communities, for example, can be addressed, as well as the different case studies that you may have that you think would be worthwhile sharing with everyone. So that's something I think very much we want to consider. It's sort of post-conflict situations that may demand this kind of attention.
Yeah, it's a really great question. And I know that yeah, it connects also to that trauma of communities, especially in post-conflict, where the government has been the source of bad things that have happened to them, and then it's the government that is coming in with a program. And how do you rebuild faith in government programs when people have had a bad experience in the past? Yeah.
Let me, here, Deborah has written, in difficult operating environments such as conflict areas, the situation on the ground can change rapidly and without warning. How can we best ensure safety of staff and communities during these periods? And this goes directly to what you had discussed, Angelia, of making safety the priority. Thanks, Deborah.
Yeah, and I found the checklist, that example of the table of documenting things ahead of time. In some cases, there really is that out of the blue, well, I don't know, where something happens that is completely unexpected. And I'll give whereas in other cases, when you go into a community, sometimes there's been a history, especially of insecurity, where it may not have had any problems in the last few years, but when you have that mitigation plan, that what if, in a moment when something happens, especially I think because a lot of programs staff are in different locations. And so, and I found that that is one of the most stressful parts, is where you're trying to figure out where your teams are located. And when you start in a district or you start in an area and everyone knows sort of the routes to take back, where to assemble ahead of time, it really helps. You can never 100% predict anything, but if you go in with even a rough plan, which I find some of the tools in the toolkit will help with, it helps.
Thanks. And thanks, Deborah, for posing that. Another question from Elizabeth, who offers congratulations for the presentation and the toolkit, asks that in the age of rising AI and digital innovations, any case studies available on how these might have been deployed in trachoma interventions? Are these highlighted in the toolkit?
The short answer is no. We have not had any case studies from, at least within the trachoma community, of AI being used for programming when we were developing the toolkit. I can say that where I see a connection, I know that there is currently research being done on a very small scale where AI, okay, let me start from the beginning. Within trachoma, one of the things that we do in order to determine the prevalence of the disease is we have trained individuals that go out, they flip eyelids, and they look for signs of trachoma to let us know that the program needs to continue. There is starting to be a shift at looking at, instead of having a person go out and look for a highly trained person going out and looking for trachoma, they could take a picture. And then the next step to that is, with these pictures, can you use AI in order to determine if a person has trachoma? And where there could be application is if you have communities either in insecure areas, where it is difficult to send maybe someone from the capital out to a location in order to flip eyelids, you could have a person there who's able to take a picture, and then you use AI in order to grade those pictures and tell you about the prevalence. So this is something that's currently being very, very new. We still don't know what the capabilities are, so it's not discussed in the toolkit, but I could see it becoming more of a thing in the future and having application in these types of communities and environments. You're muted, Chad.
Often happens that someone mutes me. I think too, is just as you say, with the increased use of AI, I think there's still a lot to learn about how we can apply these different digital tools to further the aims of the Trachoma program. Allison has asked to hear about how ICTC will follow those who are actively using the toolkit. For example, is there an opportunity for a community of users who can share experiences, and whether the NNN fills that role, and if so, how could people connect to that group?
So the short, I'll keep saying short answer. We have not, since the toolkit's come out, we haven't, I think it's only been out about 4 or 5 months. So we haven't followed up to see how it's been used. I would say a lot of the people who were involved in developing the toolkit represented organizations that were doing a lot of this work. So they were pulling from their personal experience of using it. But it is a good idea to think about maybe a check-in after a year to see what has helped, what hasn't, where there might be gaps.
Thank you. And Sangjan, do you want to add anything in terms of the role of ICTC in community of practice?
Thanks, Chad. Thanks, Angelia. Angelia, you answered the question perfectly, exactly as I would. Just to add, I think, Alison, thank you for your question. You mentioned the NNN. We'll probably look towards our member lead representatives and the ICTC membership first as a port of call of finding out how the toolkit is being used. And we'll do that primarily through our 2 in-person meetings, or our 2 biannual meetings, the first of which is usually mid-year and the second of which is usually held at NNN.
Thanks, Sanjan. And I do think this is an important thing to follow up on, and just not only with this document, but with the other ICTC preferred practices toolkits, just to make sure that these are serving a purpose for the community that they're designed for. So thank you for the response here and for the question, Allison. Dr. Wana, who you may have seen his introduction earlier in the chat, is asking whether the toolkit is also used as a digital data management tool in endemic areas.
No, it's the most it does around data management is just providing some things to consider when working with groups based off the needs in that community. We don't have sort of data sheets or other aspects of it. And then I see from Victoria, are there any specific regions where you see or want to see the toolkit being implemented immediately? Yes, it currently is. And some of that is because a lot of the toolkit was based off of what was being done by different organizations or different country programs. So I can speak from myself. I support Sudan, and in Sudan we have surveys, impact surveys, that we need to do this year. For those of you who know, Sudan is currently in the middle of a civil war. And as we're planning for our surveys, a lot of the recommendations that are in the toolkit we will be implementing. And it's very diverse, because how we're going to plan our movements. In one of the districts where we work, there are Ethiopian refugee camps. So we're developing our survey to meet the needs of the Sudanese government, but also the needs of the refugees within that program. I know in Yemen, when they're doing surveys, they're having to do paper surveys. In Amhara, they're having to do a mixture of surveys where some clusters have to use paper and other clusters can use phones. So we're seeing this being used now. Now, those were all examples where there's war or conflict, but we're also seeing some of the routine programs being adapted. So, for example, combining drug distributions with other vaccination programs in order to reduce costs. So, yeah, it's being used now, but I think a lot of the skills can be used other places. I really liked the next question from Musa about in many insecure or conflict areas, government forces are targets of violence. And what do you do in the context of a police or military escort? That was something that we found really interesting as we talked to different programs, and it shows the importance of the situational analysis. In one country, having the community felt safer if the police or military escort was there. They felt safer coming to an intervention, whereas in another country, they felt less safe if there was a police escort or a military presence. And so it really did depend on the context about when you would engage in that particular case, who your security is. In some cases, your security is provided by the chief. In other cases, it's provided by the military. And even in the same program, the chief may provide the security at the village level, but you needed the escort on the road to get you from the capital to the village. And it just really stressed that very context-specific situational analysis that's needed.
And then Hope is asked, does the tool support cross-border or cross-border interventions?
I think we talked about that a little bit. And really the heart of any cross-border interventions was the stakeholder engagement and that relationship building. Because if you, and I think we have a case study in there from Uganda, where the Ugandan government worked with the Kenyan government in order to provide trachoma services along their shared border. And so that kind of thing is discussed about the challenges of that, who owns the data, who reports the distribution numbers when one program is supporting another. So yes, it does touch on some of those issues.
And Gilbert has a comment very apropos to that, thanking people for the toolkit, and given the increasing seasonal cross-border migration driven by climate, other factors, how does the toolkit address the financial and jurisdictional challenges that arise when planning and delivering NTD services across national boundaries, considering that most approaches remain country-based?
Yes, and I would say the toolkit doesn't provide all the answers, but it provides guidance on which questions to ask and things to consider before you implement the program. And Gilbert is exactly right. Who pays for what, who authorizes who to move where, and I think it does highlight what we said at the beginning, the importance that this topic is only going to become more important, because as we have climate change, as people move, as we've seen conflict unfortunately increase, these populations that are moving are going to be a bigger challenge that programs need to address. But again, it's not just those populations that are causing programs not to reach their targets. So how do you address all the groups within your target communities?
I think Gilbert is a good one to ask about that. Gilbert Bayenda, who's with Fred Hollows Foundation, but the former national program coordinator of Uganda, did quite a bit of work with the border of Kenya and Uganda. So again, I think one of the reasons of bringing this group together is to, acknowledge the expertise that we have in this community to reach out to. Both Allison just wanted to note that they've been giving a lot of thought in terms of the documenting of the usage of the documents. And Sangjang has written just to assure that there is periodic surveys that ICTC conducts to really see how the preferred practices and toolkits are being used. We have another note here from Teresa, who thanks us for bringing the Leave No One Behind agenda to the table in a very practical way. Special populations have specific needs to ensure their inclusion, and that runs in parallel with the disability inclusion agenda, and there are many cross-learnings from this toolkit. So thank you for that, Teresa. I think, one thing we're looking at with this is making this document applicable beyond just the trachoma agenda, and certainly with other NTDs, but as Teresa points out, of looking at probably some of the more ignored groups, such as those people living without houses, or the disability. Really, how do we extend the inclusion of all this to whatever group? Rekha Hashi has asked, how do we plan to encourage stakeholders' uptake of the toolkit? And are there specific strategies that will be used to promote its adoption?
To me, one of the biggest challenges is that it's only currently in English. I do think if we want to see a wider uptake, and especially use at a country level, we do need to have it translated. And I think it would also be helpful to have it in hard copy. And unfortunately, that costs money. So our hope, one of our advocacy efforts, and this connects back to advocacy, is, in new funding streams, is this something that an organization can try and put funding to? It doesn't have to just be one NGO that pays this funding. If ICTC is able to collect some small donations from different member organizations to consolidate and have translations, I think that will be important. And we continue to promote it. We have, if those that are on this group have an opportunity in the future, any meeting that I attend, I usually ask for 5 minutes so I can talk about the document. And so we can always put together a slide or two to share with you if you want to promote this within your circles. And I think this connects to Taylor's question. The next one, is there a plan to revise the toolkit or release an updated version? Given we just released it, we'll give time to get more information, more case studies. And the first step will continue to be documenting lessons learned and sharing those lessons learned. Personally, I would like to see this, I think so much, probably like 90% of this applies to other NTD programs and other health programs. And I know that other diseases are also looking at this. So I would like to, I think a future version could be expanded on, just like we took what the Conflict and Humanitarian Emergencies Working Group did, and we expanded on that. It would be nice if this was the basis of maybe some of the other disease programs, taking this and then adjusting it to reflect, hydrocele surgeries are different than TT surgeries, but you're still trying to provide surgical services to different communities. So I feel like it wouldn't take much to make this more broadly applicable across at least the NTD space.
Just to say also, Taylor, that ICTC does have a history of updating manuals just to make sure that all the documents in their library are up to date and reflect new thinking. So there has been updates of a couple of the surgery manuals as well as the MDA manuals. So I think it's something we certainly do want to keep an eye on. We're starting to run out of time here. So we have two more questions here from Gilbert and from Dr. Wana of Nigeria. Gilbert asked that during Afghanistan's recent dual earthquakes, the country was simultaneously implementing its first ever Trachoma MDA, despite the complexities of working within displaced and disaster affected communities. The ICTC toolkit played a critical role in enabling the continuity of MDA operations, and Gilbert extends his appreciation. So thank you, Gilbert. And finally, Dr. Wana has suggested that the toolkit be modified, add a GPS component to it, and transform it to an app. Once data is collected, and it will reflect on your website as a heat map showing areas covered. Yeah, so great idea, Mohammed, and something we will certainly consider. So I think we're going to wrap up the questions. The one thing I would just like to leave you all with to consider, and something I see a challenge, is that we have the parameters from WHO to as far as what we mean by elimination. And we know that our donor community really buys into that thing that we have eliminated a disease. We also know that districts can easily attain the elimination criteria without addressing all the equity challenges. So, I think one of the key things that we need to consider is how do we have WHO, how do we have the donors recognize that we can't be satisfied with just elimination at the population level, but also within the subpopulations that we encounter. So just something to think about and to consider in your work. So thank you very much for your attendance. I'm going to turn it back over to Varsa for concluding comments.
All right. Thank you so much to Amanda Bradica, Chad MacArthur, and Dr. Angelia Sanders for moderating and presenting at our Knowledge Cafe today. If you would like to access the Trachoma Toolkit, it is posted on the Trachoma Coalition website and on the ICORD's website under the resources page, which you can find in the chat. And if you would like to attend more Knowledge Cafes like this, stay up to date on our activities by scanning the QR codes linking to our website and social media seen on the screen. We also have listed a couple of exciting new activities coming up. We will be hiring a regional ICORDS manager, which will be launching in the next 10 days. And we will also be seeking requests for proposals for the formation of ICORDS university subchapters in Africa. So please stay tuned for more details. Lastly, don't forget to register for our upcoming February Knowledge Cafe, and please register using the link in the chat. Thank you all for attending, and if you haven't already, please take a moment to fill out the Zoom poll before you leave. Thank you again and have a great day, everyone.